Good evening, friends. Welcome to another very interesting and very different uh, webinar from CCI. And I hope you will go back from this webinar with more knowledge, more experience, and more evidence, and so on and so forth. So today, we're going to talk about a very unusual thing which we have never talked about, is tracheostomy. Largely, we will be limiting ourselves to a tracheostomy in the intensive care unit, and we really do not really want to tracheostomize anybody ever. I wish most of my COPD patients just get maybe a little bit of oxygen. Worse come worse, a little bit of non-invasive ventilation, and 2 or 3 days down the line, they are ready to be discharged. But some people keep worsening. Viral pneumonia worsens, viral with a secondary bacterial pneumonia worsens, and kind of gets onto a situation where it is impossible to manage the patient without a tracheostomy. And first of all, an intubation. And if the intubation goes beyond a certain prescribed or presupposed duration, somebody requiring a 2 or 3 days of intubation and get extubated, no problem. But if it goes beyond that period, then what do we do? And we are left with one of the select options of doing a tracheostomy. Of course, ECMO is a very far situation where the hypoxia is just not getting controlled. But a lot of people are stabilized but are dependent on ventilation with an intubation and a neurocritical tube. If that is the story, then more often than not, we are better off doing a tracheostomy. So today, we are going to discuss this in great details to our best ability. We have Dr. Sri Harsha. Dr. Sri Harsha, welcome to you.
Thank you, sir. Thank you for inviting me.
Sort of an outsider, but well, you are most welcome to be with us.
My pleasure.
It means a lot to us to have you on this panel, and we'll be starting with you, and then Nyrvan is going to follow. Nyrvan is MD and a DM, and in a way, he's been with us, Maharashtra, with Dr. Amita Athawale, and then eventually did his DM recently. So I think, so one way or the other, he is linked to us, the Maharashtrians, yes. In one way or the other. So, but I think the first opening batsman of the day is going to be Dr. Sri Harsha. And Dr. Sri Harsha, let's listen to you from the ideas. How do you do it? What do you do? What are your requirements? What are your safety precautions, one way or the other, in the terms of doing a tracheostomy in the ICU settings? So over to you, Dr. Sri Harsha, and after that, to Dr. Nyrvan.
Hello, good evening, everyone. I'm very thankful to the team Chest Council of India, and I am really grateful to Dr. Nitin, who is the moderator of this session, for allowing me to present on this topic, and also a special mention to Dr. Vijay Kumar Chennam Settigaru, who is my dearest brother and my mentor. And with this short introduction, I would begin my topic, which is tracheostomy, ENT surgeon's perspective. Well, I am Dr. Sri Harsha. I'm a ENT consultant, and I specialize in rhinology, skull-base surgery, and vestibular and balance disorders. And I practice in my own center, which is Sahasra ENT, which is based in Hyderabad. So, in the next 15 to 20 minutes, I'm going to speak on various indications of tracheostomy placement and various anatomy which we encounter during this surgical airway. And We'll also be discussing about various types of tracheostomy tubes and also the complications which we expect from these procedures. So, briefly, let us understand the history of this tracheostomy. It is one of the oldest known procedures, which there have been various descriptions in our Hindu mythology writings as back as 2000 BC. Then there are records of Egyptians using tracheostomy as a procedure to relieve upper airway obstruction. Then we also have some recordings from Alexander, wherein he had performed a surgical cut on the trachea to relieve his soldiers who has aspirated a bone as back as 300 BC. Then this creation of this procedure has been described several times since 1500, but no surgical standard procedure has been described until 20th century. So in 1869, a German physician, we all know Dr. Trendelenburg, has is first credited to have created the first tracheostomy tube. Then a few decades later, American pediatrician Joseph has created a series of metallic tubes. Then he also has advanced the practice of oral intubation. However, the modern tracheostomy is started in USA in 1852, and credit should be given to Chevalier Jackson, who has described this standard surgical technique, which is being followed even till date. So let us understand few definitions. What is the definition of tracheostomy? Tracheostomy, stoma creating to the skin until the trachea. Okay, and tracheotomy is the creating proper opening on the trachea. So just subtle difference between these two terms. So what are the indications for this tracheostomy? So briefly, we categorize tracheostomy into two types. One is elective and other is an emergency. So elective procedures primarily we do on patients who are on ventilator dependence. Like if you are expecting a patient to be on prolonged ventilation for like more than 7 days, then these patients we usually shift them to tracheostomy. And also patients who are under stroke or any neurotrauma who are unable to protect their airways and who are at a high risk of aspiration. Of course, these patients require tracheostomy. And primarily in our field, ENT, we do this procedure for upper airway obstruction, primarily emergencies like bleedings, fractures, injuries to upper airway, digestive tract. Then, of course, in head and neck cancers, severe infections like Ludwig's angina, where there's severe edema in the neck. These patients require emergency tracheostomies. And of course, some rare scenarios wherein there is a severe OSA, wherein all the CPAP, all medical therapies have failed. These patients, of course, require tracheostomy. And in ends, there's also a small term called end tracheostomy, wherein patients who undergo laryngectomies, of course, to create a stoma, we put in a tracheostomy tube. So, special mention about what advantages do patients have when we in prolonged ventilation. So basically, tracheostomy replaces the endotracheal intubation to wean off these anesthetized patients. So why? Why? Because patients on prolonged ET tube tend to develop subglottic stenosis. So this is one of the dreaded complications which wherein we expect. So tracheostomy performed in these patients in early stages reduces this risk substantially. And also when you put in a tracheostomy tube, the dead space is very much reduced, so the work of breathing is simplified, and you also have better control of lower airways secretions. So there are two types of surgical airways. One is the cricothyroidotomy and the other is tracheostomy. Some people do call cricothyroidotomy as mini tracheostomy. It is like an emergency procedure where you, if you, the patient is suddenly suffocating, you just put in a needle through the cricothyroid membrane, and it's you create a temporary airway. So meanwhile, you can convert it into a regular tracheostomy once the patient is stabilized. And of course, the traditional tracheostomy is called the open tracheostomy, which we do in operating theaters. And percutaneous tracheostomy is, however, the recent trend and usually performed by intensivist pulmonologists, and it is usually done in ICU setups. So, tracheostomy tubes come in various materials. The commonest being the PVC tubes, then of course the metallic tubes, then the recent silicone tubes. And in these varieties, there are again two types. One is the fenestrated, wherein there's a small hole which allows the air to pass through the vocal cords. Primarily, these tubes are for people who want to allow, if you want to allow phonation. And there are again two varieties, cuffed and uncuffed. Where cuffed ones, if the patient requires the positive pressure ventilation, you can insert a cuff tube. And of course, the size of the tracheostomy tube, it corresponds to the tracheal diameter. And standard adult tubes are somewhere between 6 to 8. You can select based on the patient profile. And pediatric tubes are also available. So just some pictures of tracheostomy. You can see that there's a cuff tube here, and there's a fenestrated on the right side. So these tubes are very simple. They just have an outer cannula which keeps the tracheostomy stent open, and the inner cannula can be removed for cleaning, and it can be replaced by another new tube sufficiently. And there is a small plastic operator tube. It is primarily to introduce the tracheostomy tube without creating any trauma in the trachea. Then, of course, there's a small faceplate which sits against the neck to anchor the tracheostomy tube. And there is always a small balloon which we can inflate in case the patient is requiring a ventilation. So let us briefly see the operative technique for open tracheostomy. So in an elective settings, it is always recommended to obtain adequate consent before we perform a tracheostomy. It is always important the patient and the attenders understand the rationale behind performing this procedure, and they should understand the post-operative effects of tracheostomy such significantly, which is the lack of phonation. The patients cannot speak after tracheostomy, and we have to inform them that it's a temporary phase, and they would usually can phonate once the tube is removed. And they should also be made aware of various complications which might arise from this procedure. And before performing a tracheostomy, it is always advised to do certain blood profiles, especially coagulation. So, since bleeding is a very significant complication we see, so always make sure that your coagulation studies are normal in an elective setting. Of course, in an emergency, we don't have such luxuries. So, how before performing the procedure, the patient is placed in a supine position. The neck is fully extended. We can place some roll or shoulder roll underneath the shoulder to get a full proper extension. Head can be stabilized in the head ring. And it is always important that you maintain the shoulder symmetry. So the midline structures should be in the perfect midline. They should not be skewed to one side. Then, of course, we sterilize the incision site with antiseptic solution. Then, infiltration can be given with standard solutions like bupivacaine, if long term, or a short anesthetic like lignocaine, with 1 in 1 lakh or 2 lakh adrenaline dilution. Then, it is always important that you check the tracheostomy tube before you start your procedure. So choose the proper size and always check for leaks before you begin the procedure. So the anatomical landmarks are always marked. So always palpate the thyroid notch, then 2 finger breadth beneath it is a required landmark, and the sternal notch is the lower limit of your surgical markings. So once your landmarks are marked, a transverse incision is given just 2 finger breadths before beneath the cricoid notch. Then the incision can be either vertical or standard horizontal. Horizontal incision has a better cosmetic, leaves a little cosmetic mark. So for young patients, always prefer horizontal incision rather than vertical incision. Once you incise the skin, you can dissect through the subcutaneous tissues, and once you remove the platysmal layers, you will find the strap muscles. You can dissect them carefully in the midline. So one complication once you reach the strap muscles is sometimes you might encounter small anterior jugular veins. Usually they don't bleed too much. If you have a cautery, you can just cauterize them. Once you go beneath the strap muscles, the next structure which you will be encountering is the thyroid isthmus. Always be careful when you reach up to the thyroid isthmus. Either you can divide it in the midline with a cautery, or you can pull the isthmus upwards with a isthmus hook. So once you reach this procedure, you should always be careful regarding hemostasis. Once your visualization is clear, then you can start exposing the trachea, dissecting by bluntly dissecting in the pretracheal fascia, and you get this wide tracheal structure. So tracheal window, this is personal choice. Some people dissect between third and fourth ring. Some people do it between second and third. Of course, if you are planning for a future laryngectomies, it is always it is you have to take account of the future procedures. So once you decide which ring to incise, you can mark it with a small cautery. Then the width of the tracheostomy incision should never exceed more than 1/3 of the ring tracheal diameter, and uh, the window of the tracheostomy is also never exceed more than 2 tracheal rings. So of course if you make a bigger stoma, you might encounter various complications like air leaks and all. So once you perform the tracheotomy, then you can visualize the endotracheal tube which has been placed. Then you can instruct your anesthetic team to slightly pull the tracheostomy tube up. Once you have a correct tracheostomy tube in size, the trocar, plastic trocar is inserted inside the tube. Then you can insert the tracheostomy tube through laterally, and you can secure it by lubricating the trocar, of course. And then you twist it in and you insert the tracheostomy tube. So once the final position is achieved, the cuff is inflated, then the sterile connector is connected to the ventilator tube. Skin incision can be closed if it is large enough, and the tracheostomy tube is also secured to the skin. So immediately, always check for any bleeding in the tracheostomy site. Check for any air leak in case you made a bigger opening in the trachea. Then one of the complication we expect is surgical emphysema. Just palpate the skin if you see any crepitus. If you are expecting any complication, always do a chest X-ray to check for pneumothorax. Then the patient is placed in reverse trend length position, and the tracheostomy tube is secured so that it is not pulled laterally by the ventilator tubing system. So then all the tracheostomy tube components like trocars, spare inner tubes are secure. are should be sealed in a bag and given to the patient attenders or the nursing staff who is taking care of the patient. And of course, you require a trained nursing staff who can take care of this tracheostomy patients who are also aware of potential complications which we can expect. And most importantly, post procedure humidification and nebulizers are very much important to reduce the complications as well as to improve the compliance. And this cough inflation and deflation should be done only once the risk of aspiration is passes over the time. And almost a few things which the surgeon should keep in mind is never deviate from the midline. Once you deviate from the midline, you might damage contents of carotid sheath. You might perforate the esophagus. You might cause damage to recurrent laryngeal nerves. So, a key to avoiding these complications is always have adequate exposure. Once you have adequate exposure and hemostasis, your incidence of complications are very much narrowed down. And whenever you in doubt, always palpate the position of cricoid with your little finger and ensure once you're confident, then only go ahead. So sometimes early post-operatively, the tracheostomy tube might be accidentally extubated. You can just push it back, or you can confirm with flexible endoscope. Then, or you might replace the new tube in case. And one of the complications post procedure is always the tube blockage. So always ensure that caretakers regularly do adequate suctioning. And local infections, just like any surgical procedure, can be expected. So adequate proper sterilization and all will definitely bring down the incidences of local infections. And of course, the dreaded complications are tracheal stenosis, tracheal malacia, tracheocutaneous fistulas do happen, even though they are rare. So always make sure the tracheostomy site is the ventilated is site is humidified adequately. Suctioning should be done regularly with saline or N-acetylcysteine. Then the inner cannula should be regularly removed and cleaned in case of some mucus plugs are forming. And the cuff should be deflated whenever the patient is not really on any ventilation, because this cuff can create local necrosis. The small blood vessels in the trachea get blocked because of this pressure. So always decrease the pressure whenever the patient is not on any ventilation. So the first tracheostomy tube can be changed anywhere between 5th to 7th post-op day. Then the sutures can be removed. If patient is, as I said, if patient does not require any positive ventilation, the cuff tube can be switched to a non-cuff tube. And even you can downsize the tracheostomy tube once the patient is able to tolerate and is able to breathe routinely. Decannulation is always planned by slowly downsizing the diameter, and if the patient is able to tolerate breathing. Once they are tolerating, then the tracheostomy tube can be removed and the wound is automatically healed. So these are the complications and which we expect. And once again, I thank the team, Chest Council of India, for giving me this opportunity. And I would pass on to the moderator for the next talk. Thank you.
Hello, good evening everyone. I am Dr. Nyrvan Baishya. I am done my DM, MD and DM in Pulmonary Medicine and Critical Care. So thank you Dr. Nitin sir for the nice introduction. Also, I want to thank my previous presenter, Dr. Shri Harsha, for a nice presentation on subcutaneous tracheostomy. So, I would deal with the part of percutaneous dilatation tracheostomy. So, this is done by clinicians, and I would like to show how the procedure is being done and any other things, small thing that we will discuss today. Okay. So we start with a case. He is a 72-year-old male. He is a known case of COPD. Comes to emergency department with right-sided consolidation. He was intubated in emergency department due to poor sensorium and type 2 respiratory failure. So he was shifted to ICU in view of further management. On day 3 of admission, patient's symptoms of fever has improved. His PCO2 also had corrected, and patient was on high ventilator requirement. He was requiring, whenever we shifted the patient to pressure support mode, he was requiring very high pressures of about 25/5, and we were not able to wean from the ventilator. Similarly, on the day 5 also, we had attempted to convert the patient to pressure support mode, and similarly, he was also requiring very high support. So, as we go along, we will discuss about percutaneous tracheostomy and how it helped in this patient. Okay. So, I will start with the introduction. This percutaneous dilatation tracheostomy was introduced by Saglia et al. In 1985. He was an Italian physician, and he introduced progressive dilatation technique with blunt tip catheters. After that, many new techniques also of percutaneous tracheostomy has been developed. Modified Griggs technique has been developed, and another Fontaine's technique has been developed of percutaneous tracheostomy. So it is a bedside procedure which uses Sellinger's technique, and with the help of bronchoscopic guidance, this procedure is much safer. I have cited this article by Dennis et al., in which they had demonstrated safety of more than 3,000 patients undergoing this procedure. The complication and morbidity in percutaneous dilatation tracheostomy is very less, and compared to surgical tracheostomy, the complication rate in terms of infection as well as bleeding is low. So we will discuss more in detail about the complication between percutaneous tracheostomy and surgical tracheostomy, and discuss in more detail in the later slides. So what are the methods of percutaneous tracheostomy? Generally, the Saglia technique, the Griggs technique, and the Fontaine's technique are the three most widely available techniques. The Saglia technique is more widely available. It is more commonly done in USA, UK, and these instruments are available more commonly. So we will discuss more about the Saglia technique. The other techniques are the Griggs technique, in which we use multiple forceps dilation and perform percutaneous tracheostomy. In translaryngeal tracheostomy, we generally not used in patients who are mechanically ventilated or intubated. So we will not discuss about that too much. So this, I would like to show the equipments of what is present in a percutaneous tract. So we have a needle, we have Teflon catheter, we have some syringes. These syringes are used one to load the needle as well as the Teflon catheter, and the other needles can be used for loading lignocaine as well as adrenaline. So we have more of blunt dilators, we have a guide wire, we have this Cook Rhino horn dilator, then we have progressive dilators also. So the progressive dilator, which has a hydrophilic end and which we generally use which we soak it in water just before performing the procedure. In preparation of the patient, we perform percutaneous tracheostomy by three minimum medical personnel. First is the person who is performing the tracheostomy. Second is the bronchoscopist, and the third either a respiratory therapist or nurse. So the respiratory therapist or the nurse helps the bronchoscopy for withdrawing the endotracheal tube. Also, he can also assist the assist the person performing the procedure by increasing the sedation as well as maintaining the apnea of the patient while an incision is being given. So the positioning of the patient, it should be remembered that we should extend the neck as far as possible in performing percutaneous tracheostomy. This is commonly performed by putting a shoulder load in behind the patient in the scapula, and we would for performing the percutaneous tracheostomy, the anatomy is very important. So we have to know the presence of the thyroid cartilage, we have to know the cricoid cartilage, and we should be able to surface mark in those patients. And then we have the sternal notch. Ideally, tracheostomy, percutaneous tracheostomy is done in between the second and third tracheal ring. So this is the ideal site for performing a percutaneous tracheostomy. But in certain instances where we have a innominate artery, in those cases either we can go a little bit below, or for all practical purposes, when we have an innominate artery, we should go with surgical tracheostomy because the safety of the procedure increases. So steps of the procedure, we are starting with how we do the percutaneous tracheostomy. So these are the markings. We have the thyroid cartilage, we have the cricoid cartilage, we have the sternal notch. So this is marked, and at the second and third costal cartilage. So before draping the patient also, we generally do an ultrasound screening of the neck, as well as we do the Doppler examination of the surgical site, so that we see for any aberrant vessels as well as the innominate artery. So in those cases, a surgical tracheostomy is preferable. So this person is demonstrating lignocaine as well as adrenaline being instilled in the surgical site. So administering adrenaline in this patient reduces the amount of bleeding. So after this, a blunt tip dissector has been used, so that we can, after a transverse incision about 2 cm has been given, and with a blunt tip forceps, he is trying to dilate and trying to demonstrate the anterior wall of the trachea, so that tracheostomy can be performed. This is the bronchoscopist who is present in the head end. So he along with the respiratory therapist, tries to withdraw the endotracheal tube just proximal to the vocal cord, so that in case of any loss of airway, the bronchoscope can be used to insert back, and then we can see that the needle is being inserted perpendicularly. So this is the bronchoscopist view, and we can see that this is the first tracheal ring, this is the second and third. So the needle is being inserted perpendicularly and downwards, and after the needle is inserted, we remove the needle and keep the Teflon catheter in situ. So there is a small dilator which is being introduced, which is seen on the bronchoscopist view, as well as the rhino dilator. We should always keep in mind that we should always do any instrumentation. All instrumentation should be going caudally, so that we don't injure the posterior wall of the trachea. This is the rhino dilator, hydrophilic rhino dilator, which is being inserted, and the dilatation is being performed, and then the trocar loaded tracheostomy is inserted. So as we have already discussed regarding percutaneous and surgical tracheostomy, so I would like to start the debate whether percutaneous tracheostomy or surgical tracheostomy is better. So this is an article published by Critical Care way back in 2016 by Delaney et al. In this article, they had seen that in RCTs involving more than 1,000 patients, in this they had seen that there is reduced incidence of infection, bleeding, as well as in this article they had seen that the mortality rate was also lower. So because it is a critical care article, so my esteemed colleagues from ENT would not like to agree. So I have also side by side presented an article on basis of ENT article, So they had said that the mortality rates and intraoperative hemorrhage as well as the postoperative hemorrhage was almost equal. There was no statistical significant difference, but the procedure time and the infection rates were much lower with percutaneous tracheostomy. So, in following up of the case, so after day 7 of the patient, we did a percutaneous dilatation tracheostomy on the patient, and after doing a percutaneous tracheostomy, patients had started feeding well as patient started communicating with his relatives. So at that point, his more relatives had come, his physiotherapy also improved, and then patient's ventilator requirements had reduced. So on day 13, we had decannulated the patient, and day 15, we had discharged him home. So these are my references. So from where I come from, so until there is a happy ending, just like our patient, it is always picture abhi baki hai mere dost. Thank you.
Yeah, wonderful deliberations from both the speakers, and I really enjoyed it. And great Dr. Sriyasha and great Nirvan. So I'm going to start the controversies. I think, I hope you don't mind that. But at the same time, I think let me ask this question to both of you all. I mean, firstly, Dr. Sriyasha, and then to maybe Nirvan. Uh, who is the best person to perform a ICU tracheostomy? Is that an ENT guy? Is it a general surgeon? Or is it going to be a intensivist who does a percutaneous dilation? So let me start with Sriyasha.
So, as you said, it is really a controversial question. So, an ideal answer for this question would be any person who is competent enough to handle all the complications of tracheostomy uh, is an ideal candidate. So, if you say as a ENT, we are well aware of all the anatomy of the neck. Any complications, of course, we can readily do it. Any tracheostomy can be converted into an open tracheostomy at any point of time. So if you have a ENT surgeon in your team, ideally it is good. So anyway, nowadays percutaneous tracheostomy is picking up, wherein any intensivist or physician or pulmonologist are able to do. That is my opinion.
Yeah, I think very well put, Dr. Sriyasha. I think you have a counter to this, Nirvan?
Sir, if the anatomical landmarks are seen properly, and as in our pulmonologist perspective, we see very thin built patients where we can properly delineate the anatomy in front of the thyroid, cricoid. If the anatomy can be properly seen, then a percute tracheostomy is almost as good as a surgical tract. But in some cases, like we have our OSA patients where it is a thin neck, short neck, and in those cases, I think surgical will be a better option. So a case by case basis will be more adequate rather than a blank statement for the questions.
Let me ask Swapnil. I mean, hi, Swapnil from Nasik. How are you? I think this is a question to you. I mean, what is the role of a bronchoscopy aided tracheostomy? I mean, if you really ask me, most of the times when you are doing a tracheostomy, there is a tube in place. And if the tube is in place, you know where you are going. I mean, very rarely somebody would be truly idiotic to go into beyond this side or that side of the tracheostomy tube. Of course, I mean, withdrawing it is a different story when you are having the luxury of having a guided session, and that's a different story altogether. But so is it a realistic option for majority procedures, or is it relatively selected to only a few patients where you have that access?
Those patients who are very critically ill, I guess, many of the surgeons want ET to be in situ while doing a tracheostomy, because they want open airway or airway to be secured all the time. And as the time is very less during this procedure, so the bronchoscopy guided tracheostomy will be helpful when we withdraw at the time of making a tracheal stoma. We need to take out the TT tube while doing a tracheal stoma, provided it should not that much come out of the vocal cord. So it should be your TT tube should be in subpneumatic space. So definitely in such scenario, bronchoscopy guided under visualization tracheostomy will be better to have under vision care. Number two, in percutaneous tracheostomy, the accidental puncture of posterior tracheal wall. That and proper selection of site, exact selection of site. These two are again the indication becomes in to have bronchoscope in situ under for the vision to prevent the advent puncture in the, because many of us, as you asked, who can do a percutaneous? So Dr. Nayan told physician can also do. So for initial few procedures to prevent the complication, to have under vision bronchoscopy guided percutaneous tracheostomy will be helpful if provided clinical condition favor.
So in a nutshell, you wouldn't mean to say that first few procedures done under guidance, and then you could do well with sort of a blind kind of a dilatation tracheostomy. Is that what you're meaning to say?
Yes, sir. Second, and while doing a tracheal stoma, how much tube to be taken out so that you should not have a lost airway. Number one, you should not come too much high so that the again putting a tube will be at risk. So bronchoscope in place will very easily we can go ahead and re-intubate the patient if we lost the airway from front side.
Absolutely, and that point is absolutely very well taken. That you can't withdraw it too much so that you are really well out of the tube, and then you're finding where and you don't know where you want to guide it. Upper air. I mean, the bronchoscope should be through the tube, or whether you are going to guide it, beyond the tube. So I think by the side of the tube. I'm going to go to Dr. Supreet and ask him. Supreet, hi.
Hi, sir.
Hello.
Hi, sir.
How do you approach this whole scenario in a morbidly obese patient? Somebody who is going to say 126 kilos and that kind of a thing. So guided dilatational or surgical? Straightforward.
Okay. Good evening, sir, and good evening, all panelists. At the outset, I would like to say thank you to CCI for giving this opportunity. So, coming to the question that we know that morbid obesity is a relative contraindication for percutaneous tracheostomy, but there are advancement in the techniques which can help in because we should understand that in patients with obesity they have increased skin to tracheal thickness, that is called the fat, and also they have short neck and decreased cricoid manubrium distance less than 5 centimeter. So we should identify these pre-operatives before doing a percutaneous tracheostomy. So these are the contraindications because these things can lead to dislodgement of the tube and also sometimes decannulation. So nowadays you were discussing bronchoscopy and ultrasound. So these are the techniques. But again, I would like to stress that ultrasound has been shown a better place and doing a percutaneous tracheostomy because you can identify aberrant vessels, you can see tracheal accesses, you can see the lumen, and also you can see the anterior tracheal masses. So I think ultrasound has an edge over a bronchoscopic percutaneous tracheostomy if you have to do in a morbidly obese patient. So that's what ultrasound has a bronchoscopy is not required in all the patients, but I must say ultrasound we should do in even in normal patient also to rule out any aberrant vessels and also any masses anterior to trachea for doing any tracheostomy.
Okay. I think particularly the short neck. Do you have any definition in your mindset? I mean, I really don't have a benchmark saying less than 1 centimeter, less than 1.5. God knows. I mean, short neck. We define. Is there?
So there are two things defined. One is called skin to tracheal thickness. If they say it is more than 80 mm, that is the fat, anterior fat. So that is a risk factor for doing a like percutaneous is a difficult. And the other say they say is cricoid manubrium distance, which is less than 5 centimeters. So if these things are there, they pose a difficult to do a percutaneous tracheostomy. So there are two measurements we must do, and we must also take BMI into consideration. But
And
the
these
studies
both
have,
could be achieved by of course, I mean, both could be achieved by a ultrasound done prior to a tracheostomy, isn't it?
yes, but skin to tracheal thickness can be measured on the CT scan. That should
Yeah,
be if it is more than 80 mm. So that is
yeah.
done by the CT scan, and the distance we can measure from the record manual distance we can measure by ourselves if it is less than 5 centimeters. So these are two parameters along with the BMI, which poses a risk in patient with morbidly obese patients for tracheostomy.
Wonderful answer. Nirvan, I'm going to ask you this very, very difficult question. I really don't know the answer of this. An extensive facial burns and the neck burns and kind of a situation. How do you go about it? I mean, do you go Supreet's way? Do you go surgical way? Do you expose things, see what is going on, or you imagine what is there with a ultrasound or whatever help that is? What is the best way?
Sir, it is actually a very difficult question. I acknowledge that. So it will be almost as a case-to-case basis. In cases if there is inhalational injury as well as injuries to the supraglottic airways, at that scenario, an emergency tracheostomy performed by ENT surgeon will be the ideal scenario, or a surgeon. But in cases where there is prolonged mechanical ventilation for more than 10 to 14 days, and patient is intubated, in those cases, if we see the anatomy properly, if you can see the cricoid cartilage as well as the second and third rings properly, in those patients we can go ahead, intensivists can go ahead. But if the anatomy is not seen properly, in those cases an ENT opinion, when we should know when to go a back step to be taken, that should be the most important point. So in they are said that in body surface area more than 60% when with inhalational burns, if there are present, in those cases I think surgical tracheostomy is always preferable.
I think wonderfully said. I think that point should drive home a few messages. At the same time, it raises a little bit of questions for me for Dr. Sri Harsha. Well, I mean, one of them is which artery are you most afraid of? What are you most afraid of nicking without knowing? And then, I have witnessed at least one patient in my lifetime, 35 years, where a surgical tracheostomy was being done under vision, everything was in control, but then, well, something was nicked and there was a blood on the ceiling. And then, of course, I mean, we lost the patient, sorry. But so are you really worried of that? And do you really try and find that out in your routine procedure or in your ICU procedure or, in select procedure, whichever way you look at it?
Very interesting question, sir. So, ideally, we always check the coagulation profile before we proceed. So, if the coagulation is normal, most of the times we really don't encounter any aberrant vessels. As you said, sometimes there might be rare anatomical situations, aberrant arteries, aberrant vessels. And we have to be at every step during the procedure, we have to make sure the hemostasis is good and always proceed under vision. I advise never to go blindly. And as you said, rare vessels like anterior jugular veins might be, you might encounter sometimes. Sometimes we get bleeding from the thyroid isthmus. It is a rare situation. And usually this kind of torrential bleedings happen when you deviate from the midline. So always, whenever you are in doubt, ensure that the patient's neck to sternum is in the perfect midline. And if you are feeling your counterpart is when it is giving traction, make sure both are giving equal traction. Otherwise, you will be slipping to lateral end. And there are instances where people have damaged jugular veins, unknowingly they go too much lateral, and it happens in very rare situations.
I think, of course, I mean, veins relatively less innocuous. In the case which I encountered, that was an innominate artery blowout. I mean, that was like nothing could save it, kind of a situation. Of course, I mean, well, today the things have changed, and let me ask Swapnil, uh, can a convex close EBUS rather than an ultrasound from outside? Mm, have you done this any ever before, or
Never ever, sir.
incision spot? I mean, we are talking of guided, isn't it? So well, if you are using a guided procedure, why not use guided procedure from inside out rather than outside in?
Very true, sir. There are, you should have to have that much of luxury, that much of time, that much of time given by the patient to have ebuscope in situ, because it's very tough to pass through endotracheal.
Yeah,
Now, in
I
such scenario, if
understand.
you want to do a
Right.
tracheostomy, definitely
Agreed.
the indication might be
The
abnormal
size of
masses
the
or
size
abnormal
of the
vessels
endotracheal, I
within the
mean,
neck.
the ebuscope is by itself
Yeah,
is big.
and exactly. Second is the indication becomes here is the abnormal vessels anticipated, abnormal mass, which is deviating the trachea from the midline. In such scenario, to have to have exact puncture and to have midline of the trachea to be maintained, definitely EPUS-scope will be helpful, but I don't think so. It's a routine case. These things have to be, planned and elective one. You cannot use, and if provided, we should take care of that. Our EPUS-scope should not get damaged while functioning the trachea. So, it's a very high risk procedure for your scope as well. So, bearing in mind all the things, so to use a EPUS scope, which cost versus the sonography guided tracheostomy, you should take precaution
Yeah,
very well, and
yeah.
expertise should be very well while doing the tracheostomy.
So I mean, let me ask this question to all the panelists once again. Uh, I understand that EBUS is not going to be available to everybody, but a sonography is possibly available to everybody. So should we be at least when we are doing an ICU tracheostomy, where the life is really at stake, should we be calling somebody to just look at it just before and make sure that your sites are marked very well? Is that a standard of care, or is it yet not in the guidelines?
So,
I
practical,
really don't know anything about the guidelines on
the
this,
big
so
thyroid
please educate.
masses, which cover all of the trachea. So where to make an incision, because many of the time patient comes with a stridor, and emergency we advise the tracheostomy. I encountered one patient where the intratracheal mass was there and patient came in stridor. I advised surgeon to go to the tracheostomy and he could not find the space. At the same
Yeah,
time, I had to go in and I found the tracheal mass. So bronchoscopy guided intubation was done rather than a tracheostomy.
yeah.
So
No, that's an exceptional case scenario. So what is the state of guidelines telling us where to use a sonography, or should we be using it? Sriyasha, what's your thought on this?
Sir, sonography we never use, sir. We really don't have experience.
You usually don't use because you are seeing everything. You know you are the God.
Directly,
I
sir.
mean, in this situation. Okay, great. Anybody else on this? I mean, any other opinions, please?
Sir, in our case where we are doing a percutaneous tracheostomy, sir, we we mandatorily do ultrasound because we have an ultrasound in our ICU and we can monitor for with Doppler and see if there is any innominate vessels are there. So to call a radiologist to just see, I don't think it is that required. But if we can
No,
perform
the
ourselves,
radiologist is a different part of it.
yes,
The
sir,
equipment and the fact that you are trying to visualize and making
yes,
sure that you're not, it's like as simple as that. I mean, if
yes,
I'm doing an e-bus, I'm putting in a approach where I'm putting a Doppler effect on just to make sure that I'm not going to go into the vessels. As simple as that. And if that kind of a luxury is available to me, even with the ordinary ultrasound, would I be right to use it as a standard of care, particularly in ICU cases, which are most of the times high risk cases, isn't it? So I'm sorry if I'm provoking people, but I mean that's the way I'm asking. That would you do it as a standard of care next time when you are thinking of doing a tracheostomy in an ICU case? Would you do it with an ultrasound at your disposal, or you don't care? I mean, Sri Harsha is too good. He's a different. He's in a different league altogether. We'll leave him out of the discussion, but the others.
But sir, as a standard of care, I think for the patient safety, it's better to look for the vessels, because we know that it's a simple procedure, but any procedure can, if there's a bleeding, then we know that it can lead to complications. So it's better to have a.
Exactly. That's one of the standard of care consents that we take. That unexpected bleeding can lead to death, and I'm ready to accept it. Well, I mean, can I do something to prevent it? In a situation where I'm going very close to the midline and a little here and there, as Sriyasha kept saying, stay in the midline, stay in the midline. And I'm likely to go, say, 0.5 centimeters this way or 0.5 centimeters that way. Well, one way or the other, I'm in a disaster. So I would rather call for an ultrasonographist on time, on site. And I think your point is extremely well taken. I think the next question is to you only, Supreet. Given a choice, would you prefer a mid, high, or a low tracheostomy? I mean, very tricky, but at the same time, I want you to answer.
Yeah. So actually, sir, what the tracheostomy we are doing is right now it's like the common one. There's a mid tracheostomy. So how we define high, mid, and low is high is which is the tracheostomy above the thyroid isthmus, and it is the only indication is the CL larynx. And the mid is what we are doing conventionally at the second, between the second and the third tracheal ring. And the low tracheostomy is like below the thyroid isthmus, or we call it below the fourth tracheal ring. So at this point, the trachea is too deep and it's near to great vessels, so there are chances of injuring the vessels. So if you're given a choice, obviously we have to be in the safety limits, and I think the mid tracheostomy is the answer which what we are practicing. And there's an indication like CL larynx, then we can go for a high tracheostomy, and later after the surgery and all, we can go for a mid tracheostomy or a normal tracheostomy.
I think surgeon takes the call all the time to which size or where the two are tracheostomy. What do you say, Srisha? Srisha.
Hello.
Hello, am I audible? So generally, it's all the surgeons
very low.
predominantly, because we physicians generally don't.
Sorry, Moses. Extremely urgent bladder leak. Sorry. Supreet, can you come back with the last one part of your sentence?
Yeah. So, sir, I said that high tracheostomy is above thyroid isthmus. Mid is the conventional what we are doing at the second and third, and the low is below the thyroid isthmus or below the fourth ring. So, the only indication for high is CL larynx, and what we are practicing is the mid tracheostomy, which is the conventional one, the safer one. So, I think we should go with the safer one and go for a mid tracheostomy.
Absolutely, absolutely. Somebody was saying something after that. So
it's a surgeon's call usually where to do a tracheostomy all the time. Unless
no, I think most of the time surgeons are doing it. So it's I mean, the decision is theirs. Sriyasha is going to be deciding most of the times, but then one way or the other, we have to contribute. And I mean, if you are contributing, how will you contribute? That's the question. So I think, Nyrvan, the next question to you is, as a standard of care, I mean, because most of the patients that you are doing tracheostomies are critically ill, ventilated, long-term. Do you prefer using the so-called double cup longer tubes as a standard of care, or reserve it for only select situations?
Sir, the double cuff tube is generally reserved for patients where we are anticipating prolonged ventilation, just like neuromuscular disorder patients, like ALS patient, quadriparesis, where we will require prolonged tracheal toileting. In those patients only we prefer. And the second part is that because this tube is longer, there is an increased chances of resistance. So more chances of infection are also there with these tubes. So, these are the disadvantage, but the advantage is that because it has a two cuff, so we can deflate and inflate at the same time. We can do a lot alternatively, so that injury to the trachea will be less. But in the current scenario, because we have a manometry and we can check the pressures with a single cuff also, if the pressures are adequate, we can keep it at that only. So I would like to reserve it only in patients who will require prolonged ventilation, sir.
So, I mean, let's take a poll across all five of us. How many of us are doing regular pressure manometry as a standard of care? Those who are doing, please raise their hand. Those who are not doing it, please keep on.
We are doing.
Yeah. Very frankly, I mean, after 35 years, even my ICU is not doing it as a standard of care. But of course, I mean, they do it when needed, when kind of, because we have respiratory therapists who are capable of doing it, and they have the equipment. But the kind of thing is, look, in the COVID scenario, we were ventilating 48 patients on a given day. And I mean, it was impossible to do a pressure manometer in that kind of scenario. So I think realistically, the kind of load that we have vis-a-vis the kind of, the requirements of a proper pressure manometer are going to be little not so in balance. So I would say, yes, the point very well taken, should be done whenever it is possible, in whichever place it is realistic. But at the same time, it may not be practical for all situations. And if it is not, then at least think of deflating, re-inflating kind of scenario. As simple as that. This is one simple question to Dr. Sriyasha is, what is your standard care of protocol in your mind when you go post-op care of the tube? When do you dress it? When do you do a tube change? I think you said something about tube change on 5 days, and so on and so forth. So, what do you expect? I mean, or what do you do?
So within 48 hours after procedure, there will be a tracheostomy passage which gets healed. You'll have a proper stoma. So after 48 hours, if once the tract is formed, you can ideally remove the sutures. Then periodically we can uncuff the tube to prevent the trachea necrosis. And the most important thing, since we are bypassing the nose, there is a high chances of drying up of airways. So
absolutely.
Ideally, if your ICU has a humidifier room, you can put the patient in the humidifier room. If not, there are some humidifier devices like nebulizations can be done periodically. And if the humidification is bad, then there are high chances of secretions getting drying up and tracheostomy, stoma getting blocked. So your ICU staff must be competent enough to identify these blocks, and they should be regularly suctioning. And first tube can be changed maybe around 5th or 7th day.
Yeah.
So these are the simple precautions we follow. Anything can it will be case to case basis.
Yeah, then it one kind of situation. This is an interesting thing, which Sriyash has raised. It's about humidifying. So what humidifier? In the ICU settings, I have lots and lots of Fisher-Paykel humidifiers which are left, and we are reusing them back again when it comes to TP's ventilation kind of things. We have backed HMEs which are like the filters with humidifier built in. which of these you prefer and why? And what would you prefer and how would you go ahead?
Sir,
We
ideally,
start with Shresha and then everybody else.
sir, ideally it depends on the setting which the patient is. You cannot afford this in government settings. So we simply moisten the gauze piece and put it on the tube.
Okay.
That is the basic one. And honestly, if it is in a corporate hospital, there are various types of humidifiers. Frankly, I'm not really aware of them. Mostly my our intensivists take care of that. If it is a very high-end setting, of course, I've seen humidifier rooms, dedicated rooms where patient is put in there. So
I think that must be only Ambani's and whatnot. I mean, the top end, but then at least a good you. Nirvan, you are from the DM kind of a setup. So, what humidifier you would?
Sir, always with ventilation, we continue with the ventilator, that is with mechanical ventilation. We continue with the humidifier is always necessary in our scenario. So we always use the humidifier, sir. Without the
No, no,
humidifier,
the question is humidifier, which particular type? No, the backed HMA kind of a thing is good enough, or a Swedish nose kind of a thing, which is available for a tracheostomy is preferred, because we are now talking about tracheostomized patient,
yes.
possibly needing only oxygen or HFNO or something like that. He may or may not be needing ventilation. Somebody needing a ventilation, a back HMA is already there. That's not a problem, and or a Fisher Paykel. But so Fisher Paykel is the old time humidification dual servo circuit which was available. I don't know whether your generation has seen it or not. We have seen it, where there was a proximal sensor, there was a distal sensor, and the humidification was maintained through the loop, and it was maintaining humidification beautifully. We have a lot of those, old ventilators which were like discarded, but the humidifiers have remained with us. So we use that. Then we use the Swedish nose once in a while, not very commonly, but that's rarely. And we also, the most commonly used humidifier is Bactechemy, which is bacterial filter as well as humidification. So I think that's the standard of care most of the time. So I think which of these and plus minus. And
Yes,
of course, I
sir.
mean,
HME
CSI comes up
filters.
with a gauze piece, and well, I mean, that point is also well taken.
Sir,
Something
HME
is better than
filters.
nothing.
Yes, sir, HME filters and active humidifier, which you have mentioned by the Swiss nose, that we continue to use, sir, in our setup, sir.
Absolutely. Anybody else with any other thoughts on this? Supreet?
We also use the HME filters only,
Yeah,
and mostly on the dry and the wet gauge.
yeah, okay. So you combine the very old and the very latest.
Yes.
Two extremes of it. Nothing wrong in that, as long as you get the results. And very frankly, I think it depends on geography. Very frankly, I mean, if I have to really pass on a remark, very frankly, even for say a CPAP use, most of our patients do not require a humidification in a area like Mumbai or area like even Pune. Pune is getting more and more extremely humidified one way or the other because of the weather. Whereas there are areas for example, say areas in deserts in Rajasthan where humidification may be extremely important. So I think it depends on the geography also. So I think what is happening to your patient, is he getting too dehydrated, desiccated, and that is creating problems for you is I think up to you to decide in your given setting now. And the idea is add to that the air conditioning, which is a standard of care, and the air conditioning comes with a certain amount of humidification in your intensive care units is going to change the scenario dramatically. For example, if I am ventilated in a street in Delhi, I think I'll die of die of air pollution, not of the disease. Mostly, the other way around. In a In an air-conditioned setting, that's going to be almost totally a different story. So I think one way or the other, I'm sorry, I am not biased against Delhi. Sorry, if I'm coming across like that. So uh, let's move on to the next question in mind. And Swapnil, this is for you. Early versus
Sir,
late. Is timing
oh,
critical and why?
sir, generally, early means generally we do a tracheostomy in 4 to 7 days of invasive mechanical ventilation. And late means where we are anticipating that we can remove the ventilator in a week or so. So the potential reversible causes, we generally continue to have intubated patients and try to wean once we intubate, and generally on day 2, day 3, patient responds well. And our intuition says that we can remove the tube not on day 6 or day 7, provided on day 8 and day 10. So, so the potential reversible causes without comorbidities with a focal lesion, generally we do a late tracheostomy. Many of the time we do extubate and we do elective NIV in such obstructive airway disease as well. But definitely, if the disease like ARDS, viral pneumonias, multi-organ dysfunction, stroke, central neural causes, or neuromuscular causes, generally early tracheostomy is advised. Why so? Because there are many trials which has been done, and generally those who do a early tracheostomy, ventilator-free days are there are increase in the ventilator-free days, as well as a shorter ICU stay and a shorter duration of sedation is required. We reduce the long-term mortality by reducing the dead space, by giving a good tracheobronchial toileting. So there are certain definitely advantages of early tracheostomy is there if depend upon the disease per se. So early tracheostomy is preferred in such case if the ventilatory period is required for more than a week or so.
Yeah. No, I think, yeah, I think this is a common wisdom across the board, all over the country. It's true for most of us. But what are you practicing? I mean, I want to know from everybody. How many of us are doing on day 5? How many of us are doing on day 8, day 10? Something like that. So 5 versus 10. Let's put it little broader and say day five seems a little unrealistic, isn't it? I mean, and even if I know that, well, I mean, I'm likely to go beyond 2 weeks. So let's start with Nirvan.
Sir, in our setup,
Generally,
generally we take more than 7 days, at least 7 days of ventilator if we are not able to wean off, and then we consider for tracheostomy, sir.
Yeah. And then so anybody else? Supreet, you have any thoughts on this?
Sir, late tracheostomy.
Little late tracheostomy, yes.
Because there are few articles which says that if you do late tracheostomy, patient have done better and they have come out of the ventilator rather than early tracheostomy. Patient will be subjected to early surgical interventions. So there are few trials all like that, but it depends on the disease also. Suppose we have a GBS or a ALS kind of amyotrophic lateral sclerosis and motor neuron disease, that we can accept. But otherwise, if the overall the other diseases which have a good prognosis, we have seen that some patients, if you do prolonged ventilation also, they come out rather than subjected to early tracheostomy. So these were the trials which I'm showing, which have shown that if you do a late tracheostomy, the prognosis it is 1/3 patient are safe from early surgical intervention. So usually we prefer only after 10 to 14 days only.
I think there is a logic in everything which everyone has said. I am sure Supreet Sri Harsha is going to hate you. I mean, you're calling him too late in the game. But Sri Harsha, any thoughts on this? I mean,
So as
generally,
everyone panelists are saying, it is the disease which decides the duration. And honestly, it is the consultant's call. Whoever is
yeah.
managing, it is their decision.
can I, can I intervene? Can I?
Yeah. Swapnil, please come in.
Generally, we take a cross reference, and cross reference person doesn't have anything to write us. We write a system, and then we take a call of the system.
No, I think the generally the call is, between, very frankly, in my setup, I don't have enough qualified and experienced in ENTs who are doing it. My general surgeons are doing it. So I mean, they are even less knowledgeable in tracheostomy or the overall critical care than even the ENTs, for that matter. But one way or the other, I think the call is left to the intensivists, or the people, intensivists and the respirator. I mean the pulmonary specialists. So one way or the other, also we come together, sit down and discuss and sort it out and take a call. And well, I mean the next question beyond that is, if I if me, my ENT or a general surgeon, my intensivist, everybody is in consensus, but the patient doesn't give a consent. Then what do you do? So it's over to you, Nirvan. And Supreet, both. No consent despite everything in place. What do you do?
Then we have to respect the decision of the family. And also, it also, sometimes we have seen, sir, if the family says no, also we have seen the patient have come out of a ventilator and tracheostomy was avoided. So I told you, I was reading for a few articles, so it was there in the articles also, like, if the decision has been taken late and the patient have come out of a ventilator and it has prevented tracheostomy, and we have seen in real life practice also. I had a patient of H1N1, which we thought that he will had a post viral inflammatory syndrome, and we thought he was not going to make his own ventilator, and we thought of tracheostomy. But after day 14 he started improving, and within 21 days he came out of ventilator, and with tracheostomy was not required. So what I'm saying, sometimes we have to respect the nature, God, and also the family decision also. Sometimes this might also affect our decision.
I think these are, life is the biggest teacher, isn't it? I mean, and it finds a way. Nirvan, you have any other anecdotes to share?
Sir, Supreet sir has almost said very nicely regarding the late, because he has mentioned, because I also have read a few articles regarding the Trackman study in which they had mentioned that late tracheostomy was better. But in recent articles, sir, where they have done in recently published in 2023 in JAMA Rhinolaryngology. So in this article were about 17 to 22 RCTs in which they had seen that if early tracheostomy less than 7 days, they had seen that early tracheostomy was better in terms of ventilator-associated pneumonia as well as ventilator-free days. So in an ICU there is high incidence of VAP, MDR organisms. In those cases, I think a decision regarding tracheostomy will be better compared to keeping an endotracheal tube.
But I would like to mention that one thing is that the tracheostomy does not prevent aspiration, pneumonia, or VAP, does not decrease the incidence. So there is no benefit of that. That is also there in the articles.
Yes.
Extremely debatable. But at the same time, one thing I can definitely ensure everybody of is, whatever is there in your upper airway is less likely to go down. Less, not 100% surely prevented, because there is a cuff in place. I mean, of course, it doesn't guarantee you a complete prevention of respiration pneumonia, not at all. Sri Harsha, this is a technical question for you. What level of creatinine are you comfortable? 3, 3.5, 4, 4.5, 5, 6. Where do you take a call? Say, oh, well, I mean, I'm not going to touch this patient unless until you get the creatinine a certain level.
I really didn't understand this question. I mean, how is it related to tracheostomy?
No, it's related to you only, because you are the one who is going to take the incision.
But
And the uremic dysfunction of platelets is irrespective of the platelet counts, it's irrespective of the INR, it is a uremic dysfunction of platelets. And if somebody bleeds and bleeds and bleeds,
but
you are the one who's in the so no, I'll tell you. I mean, I'm a bronchoscopist. I'm an E-bus guy. I do thoracoscopies. So a creatinine in more than 3, I am a little bit uneasy. But uh, these are elective situations. Most of the times I am dealing with. Whereas what you are dealing with is critical situations. So what is your cutoff in your mind? Do you have any cutoff, or you go by whatever the ENT guy says? I mean, whatever the kidney guy says or whatever the intensivist says.
Honestly, I've never worried about creatinine levels. I really don't take. So in an emergency situation, I really don't have a choice. As long as I have a cautery in my hand, I'm really not worried.
Yeah, I mean, somebody with a stuck bone in the upper larynx, and you are just doing a tracheostomy, it's a different story. I agree. But when it comes to in a critical care scenario, it's a different ballgame.
As I said,
Yeah.
sir, if it is really an elective procedure, maybe we can wait if the nephrologist says so.
Actually, sir, the guidelines
Yeah.
the
Yeah. So
actually the guidelines say that if it is platelet is less than 50,000 or INR is more than 2, that is a contraindication. But I think we know that uremia causes platelet, not thrombocytopenia, but platelet dysfunction. So that
absolutely.
platelet dysfunction, yeah, we know that can cause bleeding, but as such, there is no mention in the like that is a contraindication creatinine. But definitely, if tracheostomy is required, it is an emergency one we did not see. But if it's an elective one, definitely we can work on it and wait for some 1 or 2 days to get creatinine getting better.
Yeah. Any other thoughts on this? I mean, anybody has sort of followed any protocols and of course, I mean, I try to get the the creatinine to the lowest possible level, place to the best possible level that I can. It could be 50, 70, 1 lakh plus, whatever that is. But whatever is the best possible that I can achieve in the given scenario. Of course, critical care scenarios are not going to be ideal. They're far from the ideal world. And of course, I mean, I'm probably never reached to, I mean, wait to get to the golden point where I have everything perfect. It's not going to happen. But at the same time, I get to the closest to the best possible scenario,
Best
and
possible.
then order. So kind of of course, I mean, there is some certain risk to be taken, and we take a informed consent for that. There's no question. Extra bleeding, the chance of things getting out of control, kind of scenario. Uh, I mean, now we are moving a little ahead, and Swapnil, I'm asking you, TP trials versus pressure support trials, extubation versus post-extubation NIV use. I mean, these are too many questions in one go, but I think, I mean, when you are trying to get somebody out of the tracheostomy,
Generally,
and
when when we do a tracheostomy, there comes generally we keep it for more than 7 to 10 days rather, and
yes,
till the time the nutrition factor matters a lot while giving a spontaneous breathing trial.
yeah,
So
yeah.
respiratory effort, consciousness, and his nutrition. If we all three are well managed, we generally will give the TP's trial, and we generally do a ABG to see how the respiratory muscle failure is there. In
Yeah,
such
I think
scenario, we give a pressure support trial more rather than
absolutely.
that.
I think
Number one.
I also tend to use more pressure support trials rather than the so-called TPS trials, which are again, I have to use a Swedish nose or something which will make sure that the humidification doesn't get compromised. That's one part of it. But the other
Right.
important part is most of these patients do not have adequate muscular strength and more importantly,
Right.
adequate muscular stamina. So
Right.
the question is more directed towards that are we going to be more inclined towards, even if I say a decannulate, will I use a pressure support, or even a SIMV if needed by an NIV route, even after decannulation, or I'll
Generally,
just
what
decannulate and I'll wait till that very end where the patient just walks out. He throws the tube out and walks out of the room. As simple as that. I mean, if he's that good, then we don't. He's not needing us any to decide for him, isn't it?
Generally, in a obstructive airway disease, while doing many of the time, patient the TPS trial or spontaneous breathing trial fails, and there we take a call generally to extubate and give elective NIV. I think that
Yeah,
is the only condition what we taught and what we see. The extubation with elective NIV is better compared to the waiting for the long period of intubation and then thinking of tracheostomy for the same reason we is failing because of safe. So
exactly.
that is the one way where we can think of extubation and elective NIV.
Absolutely, absolutely. Uh, mm, Dr. Supreet, I mean, this is very philosophical. I don't know. I don't know whether you know the answer to this question or not, but this I'm directing it to you. Is tracheal stenosis reducing over the last decade? I don't know how long you are practicing. I have seen too many of them 35 years ago. I have managed too many of them. I have put stents in where I should not have put metal stents. All kind of funny things I've done. But I think over last 2 decades or so, or even at least over the last decade or so, I think they are reducing. Is that true? The tracheal
Uh, yeah,
post
yes, sir. Yes, sir. Tracheal stenosis is like the complication is around the percentage is around 1 to 20% cases develop, and we call stenosis when it is more than 50% of lumen is compromised. So majority of patients may have some kind of stenosis, but it is significant only when it is more than 50% of the compromised tracheal lumen. But definitely we have seen the cases down because because in the advancement of the procedure and the correct techniques, because the one of causes for tracheal stenosis are like infection, then stoma infection, the stoma skin infections, hypotension, and also the cuff pressure. That is the main thing, and damage to the cartilage. So with the improved technique, the cartilage damage and measuring the cuff pressure appropriately, keeping it in the limits. So these techniques have reduced the number of tracheal stenosis, but definitely we must not rule out one must not say that tracheal stenosis patient cannot develop. They can develop. Suppose if a patient of after extubation or a follow-up develops a breathing difficulty or a stridor that is a clinically evident, then we must rule out these things by doing an imaging or a bronchoscopy. But definitely with the improved techniques and the improved care level of care in the ICUs, I think that the kind of stenosis has come down.
To add, Supreet, many juniors have come, many webinars, many hands-on courses are going on. So the now newer ones are, once we diagnose their very low threshold, they are getting treated at every possible ways. So probably that might be the another reason.
Any other thoughts on this? I mean, I have something to add. The ENT person, see, Harsha?
Definitely,
Stenosis post intubation. I mean, post tracheostomy or post intubation, either ways.
sir,
Is it going
honestly,
down?
have such a long
And
experience as you to whether it is reduced or not. We do occasionally see cases, tracheal stenosis cases, but as my seniors, my teachers do say, as the ICU care improved all the time, the cases are definitely coming down.
they are coming down. I also think so. So over a period of time, they are coming down. No doubt about that. I think once upon a time, I remember a situation where I put two metallic stents, one below and one above. And then, that question of, beautiful answer of Montgomery's tube. I missed it out in the first time. And then we did around 25 odd Montgomery's tube. So any opinions on this? I mean, is it still relevant if it is needed? Because once you have put in a tracheostomy tube, there is something going to be below and something going to be above. So a Montgomery tube is possibly one of the best and the cheapest stent, and it stays in place. See, I put in a silicone stent, beautifully put, but can migrate either upwards or downwards. Whereas a Montgomery tube, because there is a T component of it coming out stays in place and is good enough. 20 years ago, we did a good series of, in 10 years time, did a good series of around 20-25 patients. And did extremely well. But I don't know whether today's generation is exposed to this or not. And are you putting silicone stents? Are you putting metallic stents? Removable metallic stents? Why stents? I don't know what your answers. So please, one by one.
Honestly, it depends on the expertise. The surgeon or physician, if they are more trained in one particular field, you can use it. Silicons, everything have a role now.
I think so. Yeah. Any other thoughts on this? One of the questions which has been asked by Shashank from Andhra Pradesh, Nellore, is what about long-term follow-up and of the tracheal stenosis? And I think we have talked about a little bit of that, and we'll see what more we can add, our faculty can add. He also has please shed some light on the pneumothorax and emphysema after a PDT. What does that mean? I don't know. PDT is what?
Percutaneous tracheostomy.
Percutaneous dilation. Okay. So I think Nyrvan, you have to answer this.
Sir, regarding the percutaneous tracheostomy and incidence of pneumothorax, because in our patients of COPD patients, there is an incidence about 1 to 2%, but but it is very less, and we always have an ultrasound in our ICU, so we check for the we check for any in the M mode we see for the barcode sign in these patients just after the procedure. And we also get an X-ray then at least 3-4 hours after, but I have not come across any case of pneumothorax still yet.
So Shang from Andhra Pradesh, Nellore again asks, can PTP perform in children less than 12 years? I am not very sure on this, very frankly. But at the same time, I think if it is life-saving, I will do it. I mean, as simple as that. So.
But actually, sir, it just said that you must do surgical in children less than 15 years because the trachea is immature. It is immature and soft, so you might lose the airway. So in that children less than 15 years, it is recommended that we must do surgical tracheostomy.
Well, I mean, it's extremely contentious kind of a question. I really don't have a very perfect answer for it, but I think I would rather go for a surgeon doing it if that is not available, and PDT is the only technique available. I'll do it. Life matters more than anything else. Dr. Praveen from Andhra Pradesh, Visakhapatnam asking, while reinserting a tracheostomy tube in an accidental tracheostomy tube coming out, how do you prevent it from going into a subcutaneous tract? Well, I mean, $1 million question. I don't know the answer to this also. Somebody knows it. I mean, use an ultrasound. I mean, the timing available to you is so short. I mean,
sir, here I can answer this question from my perspective.
Please.
Suppose if the track has already formed, usually it happens in 48 hours, the chances of going into false track is usually low.
Yeah.
But in initial 48 hours, you might go into the false track.
Absolutely.
Here you can check whether the tube is in trachea or not by two ways. Practically, I'm speaking. If the patient is awake, conscious, you can check for air blast. You can ask them to forcefully expire. You get an air blast or you can put in, if it's on ventilator, you can just palpate auscultate with your stethoscope. If it is ventilator, usually it's in the
Absolutely, absolutely. I think makes lot of common sense, and it's a very very practical approach. What Doctor Siyasha is saying. Dr. J. Praveen from Andhra Pradesh, Visakhapatnam is asking, what is the procedure of inserting an emergency tracheostomy tube by a critical care specialist? I mean, let me answer that. I mean, you should not be attempting that unless until you're trained to do it, or you have been, observed by somebody, you've taken a specialist training. Don't really do that. I would rather try and intubate a patient. And if it's not realistically possible by conventional intubation technique, use a bronchoscopy guided intubation, one way or the other. Extremely rarely you will require a emergency tracheostomy insertion in a patient. For example, somebody who's got a very bad subglottic stenosis, and you have to just put in a tube. But then, I think, well, dilatation technique, but somebody has to be trained in your institute to do that. This is from Dr. Aman in Jharkhand, Ranchi. Covering the tracheostomy hole by a weight gauge is recommended, and for how long is it recommended to repeat the gauge wetting and placing? Once again, I don't know the real answer to this. I mean, this is something which is common sense. Most of us have been doing it one way or the other. We have been doing it for a very long time. Dr. Siyasha mentioned it. So,
So
is there any evidence on this?
I have one question again to related to the same. So how
Yeah,
frequently
sure.
we should nebulize such tracheostomy patients? By what 3% NS or to what nebulization and how frequently we should nebulize each and every tracheostomy patient to
Very
maintain
frankly, I
the
mean, I'm not fond of nebulizing tracheostomy patients just for the fact that they are tracheostomies. If somebody requires a nebulization, I'll do it. If somebody is not requiring a nebulization for the fact that if he has no asthma, no airway obstruction whatsoever at all, and I'm not needing a bronchodilator, I'll just put normal saline installations and suction it out. If necessary, I'll do even a subglottic suctioning, and if necessary, if that is what is necessary. So I mean, I might just put in a laryngoscope and go beyond. Most of my respiratory therapists, we have a team of 7 respiratory therapists in my ICU, and they are extremely well trained in even intubating patients in the midnight. Very frankly, 2 a.m., 3 a.m., my residents are worse than my respiratory therapists in intubating. So their ability to suction somebody by the side of the tube, or just deflating the cough and getting the secretions out, if that is what is necessary, can be done. So I think it depends on the situation, geography, expertise, and overall situation scenario. It's not going to be a universal kind of a recommendation that you do this or you do that. What is relevant to your situation? Somebody is dying of a blocked tube. You have to get it out and put it back in again, and try and make that best possible effort of getting it in the right plane. So I mean, any other thoughts on this, please? Anybody from the panel? Nirvan?
I would also like to go ahead with the answer, because just for the sake of nebulizing it, we would not go ahead. We would like to use an active humidifier if possible, or an HME, if that should suffice, rather than using an HME.
Absolutely. I mean, I'm just blindly nebulizing people, not a real answer. But say, move to a secondary care, or I mean, from say tertiary care cities to secondary care cities, where things are not available on routine basis. A normal saline nebulization may be relevant. But one thing, let me warn all the people who are doing nebulizations as a routine of standard of care in tracheostomies or non-tracheostomies patients also. N-acetylcysteine by itself is not that less harmful by itself can cause bronchospasm. So if you
Bronchospasm.
use it, be sure that you are not going to cause bronchospasm because of the nebulized N-acetyl system.
I was
So
about to say that.
exactly. So
I have
I
seen
think
people giving nebulization with NSL-16, Deolin, and all the bronchodilators, but I think the best thing to get out of is this: give a good hydration to the patient. That is very
exactly.
important. And steam and suctioning is required every SOS, whatever 2 to 3 hours, rather than giving him loading with nebulization. And also, we know that nebulization can also cause candidiasis, airway candidate. And also the other thing is NHL-16 is a bronchoconstrictor. So that I have seen people giving an NHL-16 for the after tracheostomy just to get out secretions. So I think
Supreet,
hydration and our stays is the most important thing.
your point of hydration is extremely well taken because I 35 years back I worked in Cyan ICU in Mumbai, and the first thing that we would do for an asthmatic who comes with a status asthmatic is we put in a Ryle's tube so that we could nebulize him. Of course, IV and IV fluids and IV fluids and lot of fluids, and those lot of fluids will make the secretions less stickier because the only bronchodilator we had at that time was salbutamol. Nothing else was available. The only thing which was available was Saba, and then whatever doses of steroids and derifilins and whatever not. What was there. I remember running an aminophylline OPD once upon a time. So I think taking care of in Rajawadi in Ghatkopar. So I think crazy things happen in life, and over a period of time we change our strategies, and today we don't touch aminophylline, almost don't touch it in asthma. So that's a different story altogether. But I think as we grow better, we have to rationalize what is the best possible scenario, and an optimum hydration is the correct approach. Nothing better than that. If you do that and the secretions are getting mobilized, you don't need to do anything else. All you have to do is put in a suction catheter in a correct way and you'll get the secretions out. As simple as that. The last, I think, take-home question I will ask to everybody is we've talked a lot about tracheostomy today. Tracheostomy with a little more preference towards, little more inclination towards ICU. So let's start with the junior most. Who is junior most? Nyrvan?
Yes, sir.
Yeah. So let's start with the smartest guy around. We are the dumbest. So I'll end at mine. Nyrvan, what are your take-home points?
Sir, regarding the surgical tracheostomy, the percutaneous, how it can be done, then how the double cuff tube, as well as we have discussed regarding how to maintain the hydration of the patient, as well as the humidification, that points, and as well as post tracheostomy care, that is what will be the most important part of this lecture.
Swapnil, we come to you.
First of all, thanks to you, thanks to CCI for organizing such a good event and involving us as a part of same. So, as tracheostomy routine advice, early tracheostomy takeaway message are better in a long whenever we suspect a long stay of the ICU stay, irrespective of whatever the trial stay of late tracheostomy. I am sorry, Dr. Supreet, but early tracheostomy will be better. Certain cases where we anticipate the difficult tracheostomy, definitely bronchoscopy aided intubation as well as tracheostomy will be better. To start with the percutaneous dilatation tracheostomy, definitely to have assistant in hand of expert as well as bronchoscopy in hand will be better. And to anticipate the problem is much more important, so that sonography will be much more rather than going on overconfident way for the intensives rather than Dr. Druha. So these are my takeaway points.
Absolutely. Supreet?
I must say that every pulmonologist, intensivist must know the technique of tracheostomy. And I think we are not touched upon cricothyroidotomy, that is called mini tracheostomy. It can be useful in emergencies procedures. Sometime who's dying of laryngeal edema on a road or something like that, you must know where to put the right needle at that time. That is cricothyroidotomy. So that is a life-saving procedure. You must, at least you must know that, at least if you don't know tracheostomy.
As a bronchoscopist, I am doing a trans-cricoid kind of an anesthesia, local anesthesia for
Me
everybody.
too, sir. I also
So
give that.
I'm 100% sure I know where to put the tube.
I am also giving xylocaine before bronchoscopy.
Absolutely, absolutely.
Yeah.
Intratracheal oxygen as well.
Dr. C. Harsha?
Tracheostomy is one of the important life-saving procedures. Not just physician, I'm sure every MBBS passed out must be able to do this procedure, because we never know when emergency landing upon you. And rest of the take-home points, anyway, the panelists have summarized. This is just my point, which I wanted to stress. Everybody must be able to. Wonderful.
I think we have had a wonderful discussion over last one and a half hours or so. I think beautifully done. Everybody has contributed. I thank Dr. Harsha, Dr. Supreet, Dr. Nyrvan, and Dr. Swapnil for this wonderful deliberation. I hope all of us have gone richer, learned a little bit. I'm sure I have learned a little bit today. So I think we all go richer, and I'm sure all the people who have attended have benefited from this magnificent webinar. And we look forward to many of such webinars in future from CCI. Thank you. Thank you very much. And I conclude this
Thank you.
session.
Thank you, sir.
Thank you, sir.
Thanks a lot.
Thank you.